circulate it in my department as well.
I think it has started.
Yes,
Now
sure.
you can start. Surekha,
Yes, yes.
please.
Can you hear me, ma'am?
Yes.
Good evening, everyone. I am Dr. Surekha Khandare. I am Associate Professor of OBGY at GMC Chandrapur and MOC of today's program. A very warm welcome to all present here. Today is Star PG's 10th activity, Tense Moments. This activity is organized by Nagpur OBGY Society in association with GMC Chandrapur. Today's topic is preeclampsia, which gives many tense moments to obstetricians and patients also. Approximately 76,000 women and 5 lakh babies lose their lives each year because of preeclampsia, and 60% of the maternal deaths are preventable. So I invite Dr. Sushma Deshmukh ma'am, President NOGS, to deliver welcome address. She is a very enthusiastic, creative, and she is also a very great poetess. And there is no need to mention that hundreds of the students and consultants are thankful to her for starting the Star PGCon activity. And it is very well perceived not only in India but also in USA and Europe. Welcome, ma'am.
Thank you. A very good evening to all, respected seniors, friends, and my all budding PG students. It gives me, today peaceful and relaxed feeling to welcome you all for today's 10th webinar of PG Star Series by Nagpur OBGY Society in association with the Government Medical College, Chandrapur. Thanks to Dr. Prashant Turke sir. And today I said you peaceful and relaxed. Why? Because we are going to discuss and solve the tense moments for us, for patients and their relatives. Now we are entering in the festival zone of India with lots of deities to bless us. And we know that the pregnancy is nature's wonderful creation with dreams and expectations, but sometimes on unexpected situations, making everyone tense and stressed. If not taken care timely, then it will progress like a flash, not giving time to think. Tense moments to doctor, patient, and baby is in danger. So, you must be knowing, yes, what I'm speaking, it's the hypertensive disorders of pregnancy. So, Dr. Dipti Kaveri, a dashing young lady, ventured to present a case on preeclampsia. So, we wanted a brilliant opinions to solve the riddles of preeclampsia as well as to guide us all. Dr. Jyoti Jaiswal and Dr. Anita Yadav, thorough academicians, will be going to relieve our stress moments. Welcome Dr. Jyoti Jaiswal, Dr. Anita Yadav, and Dr. Dipti. But we know HDP is a threatening condition. Can we knock down it? Can we prevent it? We know that the answer is no. But at least we will learn thoroughly. We'll try to screen meticulously. We need some motherly person with knowledge of Brahman to handle it vigilantly. And her name is also giving a divine touch. She is Dr. Girija Bagh. Welcome, Dr. Girija. She is going to speak on screening for HDP. In this journey of HDP, we require calm and composed mind with Madhur smile, and we are having charming, sweet, intelligent lady, Dr. Madhuri Dabde, and a handsome young godly name as Dr. Roshan Fernandez. You know that Roshan means the Lord Vishnu as chairpersons. So spiritual plus academics and Madhur happiness. So welcome chairpersons. Dr. Surekha Khandare is holding the reins of all HDP tense movements. She is going to release it from time to time. I also welcome audience, respected seniors and friends. Our team academics, Dr. Anuja Bhalerao, Dr. Bhakti Gurjar, Dr. Prachi Dikshit are really constantly rolling the ball of academics to fight all the OBGY problems. And our NGS Secretary, Dr. Pragati Khadkar, will support in any odd situation. So, friends, let's release the tense moments. Thank you.
Dipti?
Yes, ma'am.
Thank you, dear ma'am, for your kind welcome address. Now we will start with our first session, case presentation of preeclampsia. So,
Yes, ma'am.
I welcome chairpersons. I want the chairperson CV, Dipti.
Ma'am.
Pragati, you want to give vote of thanks?
I was thinking I should propose, otherwise they need many persons. So if I have of the chair, then I can.
I think Bhakti, she wants to go. She's having train.
Uh,
So
okay, ma'am.
let her
So,
complete the vote of thanks and let her go.
yes, sure, ma'am. Let me request Dr. Pragati Kharatkar, ma'am, to please propose a vote of thanks.
Thank you, Dr. Bhakti. So, respected faculties and all dear friends who have logged in, a very so this is of our PE star. We have the 10th star, and I'm so proud that we are doing this program so well, and our students are getting benefit. So as HDP come just suddenly, hepatitis disorder sometime land suddenly. So is my vote of thanks landing today suddenly. And as it gives us jolt and jerks and flashes and tremors, I hope this whole CME goes on very well. So I'm thankful to today examiner who have consented to examine and guide the students, Dr. Anita Yadav.
Hello?
So much.
समझ नहीं आ रहा है
Your voice is breaking, Pragati.
क्या मैम?
Okay. Yeah. Okay.
सीवी की
Perform well.
मैम स्क्रीन
Okay.
शेयरिंग हेलो
Still not? Nine? Not audible?
No,
Now?
it is breaking. It's breaking in between.
Achha. Now is it audible now?
Yes.
And today's chairperson, Dr. Madhuri Dabare and Dr. Rohit Fernandez, thank you for accepting our invitation to chair the session. And today's MOC, Dr. Surekha Khandare. I'm sure this ride of HTP is going to be a very enlightening and very educative ride. And Dr. Birisha is there to enlighten us.
समझ में नहीं आ रहा है आप क्या बोल रहे हैं
Wish you all the best. Let the program rolling. Thank you so much.
Okay. Then we can start.
Sure.
Thank you.
Thank you, dear ma'am, for vote of thanks. Now we will move to our case discussion. Dr. Dipti Kaveri, she is a junior resident, first year student of GMC Chandrapur in OBGY department. And examiners for today's case are Dr. Jyoti Jaiswal ma'am and Dr. Anita Yadav ma'am. Next slide, Dipti.
यस मैम
Dr. Jyoti Jaiswal ma'am. She is a professor. Slide show, kindly show me slide show, Dipti.
यस मैम
She is a professor and head of the Department of Obstetrics and Gynecology in JNM Medical College, Raipur. She is a Vice President, Raipur OBGY Society. And she is also Secretary General, Raipur ISO PARB. She is a Treasurer of IAGE CG chapter. She has also held many previous positions in IMS. She was a National Joint Secretary. She was a chairperson of a peace committee. She was a past president of IMS Raipur. She had received many awards and recognitions like Dr. Suvarna Khadilkar Best Committee Award, MS Signature International Award, Naika Award, Lions Club Shikhar Award, and CG Mary Teacher Award. She has organized many conferences at the level of international, national, and zonal conferences. She has written books and chapters in FOXY and IMS publications, and she has published more than 30 papers in national and international journals. Welcome, ma'am.
Thank you.
Our next case examiner is Dr. Anita Yadav, ma'am. She is Associate Professor in All India Institute of Medical Sciences, Nagpur. She has special interest in high-risk obstetrics, infertility, gynec endoscopy, and clinical research. She is a PG guide. She was invited as an external examiner by many different medical colleges of India. And she has received Mrs. Vaxi Memorial Award for Compassionate Doctor. She has more than 30 publications in her national and international journals. Welcome, ma'am.
Thank you, Dr. Surekha.
मैम shall I start मैम
Yes, you are permitted to start your case.
Thank you, ma'am.
BP.
Yes, ma'am. Yes, ma'am. Uh, Good evening, ma'am. Good evening, everybody. Today, I want to present a case on preeclampsia. Uh, a 23-year-old female, Mrs. P, is a primi gravida with 9 months amenorrhea, is a resident of Gadchiroli. Hindu by religion, she studied till 6th standard, is a homemaker. Her husband studied till 8th standard and is a farmer by occupation. Went to Women's Hospital Gadchiroli with the chief complaint of headache since 3 days. History of presenting illness. Patient was apparently asymptomatic 3 days back. Then she had complaints of headache, which was insidious in onset, dull aching in nature, localized to the frontal and temporal region. Pain is not referred nor radiating in nature. Pain is not relieved by medication. Pain aggravated during work, and as headache was not relieved by medication, patient went to Women's Hospital Gadchiroli. There on examination, she was told her she was told that her BP was raised, and from there, then she was referred to our tertiary care center for further management. And there is history of associated swelling of lower limbs since 10 to 15 days, which was gradual in onset, started with swelling in the feet, then progressing gradually to legs and then till knees. Edema feet is not relieved by rest, and there is no history of associated tightness of rings on fingers. There is no history of any puffiness of face. This history is not associated with nausea, vomiting, epigastric pain, right upper quadrant pain, breathlessness, blurring of vision, or decreased urine output. History of present pregnancy. First trimester. Patient conceived spontaneously after 3 months of marriage, and pregnancy was diagnosed by urine pregnancy test at a nearby Anganwadi center after 7 weeks of a missed period. She is a registered case at Women's Hospital Gadchiroli, and she confirmed her pregnancy by ultrasonography at 12 weeks of gestation. NT scan was not done and double marker screening was not done. She had a total of 2 antenatal visits in her first trimester, and all routine antenatal investigations were done. She was screened for anemia and diabetes mellitus. She received folic acid tablets regularly. There is no history of any nausea, vomiting, burning micturition, fever, bleeding per vaginum. There is no history of any drug intake, hospital admissions, or any radiation exposure in first trimester. Second trimester, she had a total of 4 antenatal visits, received 2 doses of tetanus toxoid, first at 15 weeks of gestation, followed by second dose after 44 weeks. She was on regular hematinics and calcium intake from 4th month of gestation. Anomaly scan was done at 5th month of gestation, which was told to be normal. She felt quickening at around 5th month of gestation, and BP recordings were within normotensive range in second trimester. Repeat DIPSI done at 6 months of gestation and was told to be normal. There was no history of any fever, breathlessness, burning micturition, pain abdomen, or swelling over the limbs in second trimester. Third trimester, patient had total of 4 antenatal visits in her third trimester. Patient perceived adequate fetal movements, and there was no history of any pain abdomen, leak per vaginum, or bleeding per vaginum. Her previous 3 antenatal visits were uneventful in third trimester. Her fourth antenatal visit was when she had headache that was not relieved by rest and medication. Obstetric history. She is a primi gravida, married since 11 months, and it's a consanguineous marriage. Menstrual history. Sorry, it's a non-consanguineous marriage. Menstrual history. Her first day of last menstrual period was 17th of December 2022, and her expected date of delivery was 24th of September 2023. Her gestational age is 35 weeks 3 days. Age at Menak is 13 years. Her past menstrual cycles were regular, uh, 3 to 4 days in every 28 to 30 days. She uses 2 to 3 pads per day, not associated with dysmenorrhea, and there was no history of any passage of clots. Past medical history. There's no past history suggestive of hypertension, diabetes mellitus, tuberculosis, bronchial asthma, thyroid disorders, seizure disorders, and nor any hemoglobinopathies in past. There's no history of any blood transfusions and no history of any hospital admissions. Past surgical history. There's no history of any surgical interventions in the past. Family history. There's no history of hypertension, diabetes mellitus, chronic kidney disorders, hemoglobinopathies, and any major surgical illnesses in family. Socio-economic history. Patient belongs to lower middle class as per modified Kupuswamy scale. Dietary history. Patient's daily diet calorie intake is 2,200 kilocalories per day, and her protein intake is 50 grams per day. She is deficient in calories by 300 kilocalories per day, and protein deficiency is 10 grams per day. Personal history. Patient takes mixed diet. Her appetite is good. Bowel and bladder habits are regular. Sleep is adequate. There's no history of any known drug allergies and no history of any addictions. General examination. Patient is moderately built and nourished. Her height is 154 centimeters. Her pre-pregnancy weight is 56 kgs, and her pre-pregnancy BMI is 23.4 kg per meter square. Her pregnancy weight gain is 8 kgs. And on examination, patient was afebrile. Her pulse rate was 84 beats per minute, regular in rate and rhythm, normal in volume. There's no any radio-radial delay and radio-femoral delay. All peripheral pulses were felt. Her BP on recording was 160 by 110 millimeters of mercury in right arm, measured in sitting position. Her respiratory rate is 15 times per minute thoraco-abdominal in nature. Oxygen saturation is 98% at room air. Her JVP was not raised. Orodental hygiene well maintained. There was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, hyperpigmented knuckles present. There was bilateral edema feet present till knees, which was pitting type in nature. Her nails were normal and deep tendon reflexes were normal. Systemic examination, central nervous system examination. Patient is conscious, well oriented in time, place, and person, and is cooperative. Cardiovascular system examination. S1, S2 heart sounds normal, no murmurs were present. Respiratory system, bilateral air entry was present, equal on both sides, and there was no any adventitious sounds heard. Per abdominal examination, on inspection, abdomen was longitudinally ovoid, linea nigra and stria gravidarum present, umbilicus flat, hernial orifices intact. There was no any abdominal wall edema present. On palpation, obstetric examination, after obtaining verbal consent, voiding of urine, and correction of dextrorotation, her fundal height corresponds to 32 weeks of gestation, symphysiofundal height 34 centimeters, and abdominal girth 99 centimeters. On first Leopard grip, on fundal grip, soft, broad, irregular, non-ballotable mass suggestive of breech was felt. On lateral grip, on left lateral side, curved continuous resistance felt suggestive of fetal back. On right lateral side, multiple irregular tiny knob-like structures felt suggestive of fetal limbs. On first pelvic grip, round, hard, globular, non-ballotable mass suggestive of fetal head felt. On second pelvic grip, fingertips were diverging, suggestive of engagement of fetal presenting part. On palpation, uterus felt relaxed. On auscultation, fetal heart sounds were heard on left spino-umbilical line, approximately 152 beats per minute, regular in rate and rhythm. On pervaginal examination, cervical os was closed and cervix medium consistency, centrally positioned, cervical length 2 cm, head station was -2. Her sacral promontory was not reachable, sacral curve adequate, side walls were parallel, interischial spinous diameter adequate, subpubic arch admit 3 fingers, intertuberous diameter admits 4 knuckles. Probable diagnosis from history and examination. 23-year-old primigravida with single live intrauterine fetus in cephalic presentation, 35 weeks, 3 days gestational age, is a case of severe preeclampsia. Thank you.
Yes, Deepti,
Yes, ma'am.
your probable diagnosis is complete, or you want to add on something based on your examination finding?
Ma'am, it's complete, ma'am. It's a case of severe preeclampsia.
Okay.
Okay. So, Bhakti, first of all, well done. You have presented your history very well, narrated very confidently. But there are few questions in my mind that you have diagnosed that is as a case of preeclampsia. So can I know what are the basis of diagnosing it as preeclampsia?
Yes, ma'am. Preeclampsia can be diagnosed when there is a BP, her blood pressure of greater than 140 by 90 millimeters of mercury in a previously normotensive patient, taken 4 hours apart and associated with either proteinuria or any de novo presence of features of multi-organ failure like headache, visual disturbances, features of pulmonary edema, thrombocytopenia, or decreased urine output, raised liver enzyme levels, decreased platelet counts.
So here, what is that factor which made it severe preeclampsia?
Ma'am,
Headache?
on exam, yes, yes, ma'am. There was no previously she had no complaints of headache, and there is no history of any cerebrovascular disorders. So de novo headache with raised BP. So
So only headache, or there may be some other features. What was the type and characteristic of the headache?
uh, ma'am, it was dull aching in nature, localized to frontal and temporal region based on history.
I
And
could not listen about the proteinuria in your case. So have you examined the patient for edema and proteinuria?
yes, ma'am. Yes, ma'am. On investigations, all investigations were done, ma'am. After her admission, I have investigated her, and
On
I
clinical
have
examination, can you find out
pedal,
anything which could suggest it?
yes, ma'am. Pedal edema was there, ma'am.
How much it was there?
Ma'am, it was till knees, ma'am. Great pitting type of edema was there till knees, which was gradually progressing from ankles, ma'am. It
All
started 10
pro-
to 15.
all proteinurias are not preeclampsia. Nowadays, it is defined that this particular level, if it is there, then it is known as preeclampsia. So,
Yes,
how much proteinuria is said to be a marker of preeclampsia?
yes, ma'am. If we do on bedside tests by using dipstick, 1 plus proteinuria is significant, ma'am. And on quantitative proteinuria examination, greater than 300 milligrams in 24-hour urine sample is considered proteinuria, ma'am.
Is there any other test also? How do you check for proteinuria apart from the dipstick and 24-hour urinary protein?
Ma'am, protein creatinine ratio, albumin creatinine ratios.
Yes. So how much is the sport protein and creatinine ratio?
Ma'am, protein creatinine ratio should be greater than 30, 30 milligrams per millimole, ma'am.
Is 0.3 milligram per deciliter, right? And
Yes.
what about albumin and creatinine ratio?
Albumin creatinine ratio should be greater than 20.
8 nanogram per ml. So these
8
are the 4 tests we use for checking the proteinuria.
Yes,
And
ma'am.
proteinuria should be 2 plus or more. It is not 1
Yes.
plus.
Yes, ma'am.
The latest
Rightly pointed
guidelines
out.
are saying it is 2 plus or more.
Yes.
Yes, ma'am. Okay.
Deepti,
Uh, the
yes, ma'am.
weight
Please.
gain, the weight gain during pregnancy till she is having 36th week running, and the weight
Yes.
gain is 8 kg. So
Yes, ma'am.
I need your comment about the weight gain. Is
Uh,
it all right? Is it less? Is it more?
uh, ma'am, during second trimester, during third trimester there is nearly 5 kg weight gain, ma'am. And in first trimester there is approximately 1 kg, and second trimester 5 kgs. So
36
it
week
is,
running. I am
yes,
asking
ma'am.
whether for the current situation. You are telling that she is having edema also,
Yes,
and
ma'am.
up to the level of knee. So the edema up to the level of knee will definitely increase the weight. So the total weight gain 8 kg. Is it accurate for this lady? She is having 36th week running, and your diagnosis was per abdomen 32 week size. I could not find the estimated fetal weight clinically assessed. How do you assess the fetal weight clinically? You have said that 34 inches fundal height and 99 centimeters is the gut.
Abdominal guts.
Do
Yes,
you
ma'am.
have any formula by which you can take out liker is uh, if liker is not oligohydramnios or polyhydramnios? In that situation, in a singleton pregnancy, can you make out the expected fetal weight?
Yes, ma'am. By ma'am, Shepherd's Hardlock's formulas.
So have you calculated it? What is the estimated fetal weight?
No, ma'am.
You should be calculating by the either Johnson's formula or Hadlock's formula. Apart
Yes,
from the ultrasonography, if you do not have ultrasonography with you, so then
yes,
you
ma'am.
need to, and you said that head is engaged. So in that situation, the weight difference can come. Head is engaged and head is not engaged. In both the situation, it can be different. One more thing you have said about that 12 weeks of sonography has been done. So have
Yes,
you read that sonography?
yes, ma'am.
You said that NT and double markers were not done, but the 12-week sonography includes NT. So what were the parameters taken during the 12 weeks USG in her report, and what should be an ideal uh, reporting of 12 week sonography should have?
Ma'am, gestational sac diameters and crown rump length,
Okay.
uh, nuchal translucency should be there, ma'am. But in her scan, I didn't see her NT level. Ma'am.
Okay,
There was only CR
if you
level.
could got a better sonography report, then apart from these anti and double marker, what else you were expecting to have in this particular case or any case? What can be done in respect of the hypertensive disorders of pregnancy at 12 weeks in ultrasonography?
Ma'am, uterine artery Doppler,
What does it predict?
ma'am, placental perfusion is increased pulsatility index in uterine artery Doppler studies.
What it will say if it is increased?
Uh, there is increased risk of chances of her preeclampsia risk is increased.
So, if it had been done in this particular case, and it found to be maybe that it was giving you the indication that patient can have the risk of future preeclampsia. Then, what can be what could be your approach? What extra measure you could take at that time
Yes, ma'am.
at
Um,
12 weeks?
I'll counsel her, ma'am. We can start her on low dose aspirin.
Low dose aspirin till
Yes,
what time?
ma'am. Till we can start it from 12 weeks to in between 12 to 28 weeks, and it can be given till date of delivery, ma'am. Till her delivery.
Okay. And what should be the dose, recommended dose?
Ma'am, low dose aspirin range in between 50 to 150 milligrams.
So your patient was about, I think, uh, some 70 kg, 64 kg patient. You have
Yes,
a 64 kg patient. So what should be the dose?
ma'am, approximately 75 to 81 milligrams in between.
You know your patient weight, so you can easily calculate. Okay.
Okay. So you also have the first reading of BP 160 110 in the sitting position.
Yes,
So,
ma'am.
do you want to confirm it after 4 hours, or this single reading is sufficient?
Ma'am, as such, it is sufficient, ma'am, because there are uh, associated other features, and
In case there is no headache, then 160, 110 will be considered as preeclampsia or not?
uh, ma'am, we
Or
need
say,
to,
it, huh?
yes, ma'am, we need to confirm it after 4 hours again.
Dipti, you know the preeclampsia without severe feature?
Yes, ma'am. Less than non-severe type of preeclampsia.
Yes.
Yes, ma'am.
So
Uh,
what is there in the non-severe? What is the difference between the severe and non-severe type of preeclampsia?
in severe type of preeclampsia, there is systolic is greater than equal to 160 and diastolic greater than equal to 110 millimeters of mercury, and there is proteinuria, and there is associated symptoms like visual disturbances, thrombocytopenia, raised creatinine levels, um, features of pulmonary edema, and headache, and there is associated raised levels of transaminases, low platelet counts, and fetal growth retardation.
Yes, rightly said. But only one thing is that ki proteinuria may or may not be present in a case of severe preeclampsia.
Severe preeclampsia.
Preeclampsia with severe features, right?
Yes,
And-
ma'am.
Okay.
So that's why I have asked you that if this patient do not have even proteinuria, but if she is having this much of rise of blood pressure, no second confirmation is required, and she will come under the category of severe
Severe preeclampsia.
hypertension.
Yes, ma'am.
Madam, you can add on if you want to ask anything.
Yes. So what will be your initial approach for the management?
Ma'am, firstly, I'll counsel the patient regarding the other premonitory signs and symptoms, and
First
I'll make
decide
her.
you want to admit her or not.
Yes, ma'am. She was a referred case, so I want to admit her.
Okay.
I will admit her, and then make her comfortable in a left lateral position, and counsel her regarding the premonitory signs and symptoms, other symptoms, and then I'll investigate the patient by taking her complete blood counts, doing her complete blood counts, urine examination, and liver function tests, kidney function tests, and coagulation profile, and also fetal growth monitoring. I'll be doing fetal growth monitoring, ma'am.
You will not do
Fetal.
the fundus examination. Mother
Sorry.
maternal
Yes, ma'am.
monitoring is over.
No, ma'am. No. Fundus examination is.
Okay. And how you will assess the fetus?
Fetal assessment is done by fetal kick count. Ask the patient regarding the fetal kick count, and biophysical profile, and umbilical artery Dopplers, ultrasound.
Only
Uh,
umbilical artery, doctor.
no, ma'am.
You
Umbilical artery, ductus venosus, and uh, uterine artery Dopplers.
See, if you have assessed the fetus as well as the patient. If the patient do not have any abnormalities in these tests, like say the baby is all right, baby is having a adequate number of fetal kicks uh, in the your color Doppler finding, there is no finding of IUGR, everything is all right, and the patient's platelet count, etc., is also all right. Then what will be your approach for this patient further? Will you continue the pregnancy, or you will counsel for the termination of pregnancy for this patient?
Ma'am,
What
I will counsel.
madam has asked you about the management. So you have told us about the investigation part. For the
Yes,
treatment part also, you brief summarize it.
yes, ma'am. Ma'am, as I have already investigated the patient, and her all parameters are within normal limits, and but her blood pressure is high, and there are associated premonitory signs and symptoms. I have already assessed her per vaginal cervical status. I will counsel her for termination of pregnancy, as there may be other additional. May be, if I want to continue the pregnancy, there may be complications like eclampsia, and other, she may land up in eclampsia. So I'll counsel her for termination of pregnancy. And as her
What should be the
bishops,
mode of delivery? What should be the mode of delivery in this case?
ma'am, in this case, as her bishops is 5 and her pelvis is adequate, I'll go for induction of labor, and uh, induction of labor with uh, ripening agents like cerviprime, dinoprostone gel, and then I'll go for further management based on the progress of the patient.
So, agreed, Deepthi. You have started for the induction of labor with the help of the cervical ripening agent, but
Yes, ma'am.
till she got delivered, till then
Yes, ma'am.
you will not add anything else.
No, ma'am.
Only the
Yes, ma'am.
delivery is the treatment.
No, ma'am. First I'll, in order to prevent eclampsia, I'll put her on anticonvulsant medications, anticonvulsant prophylaxis by giving her magnesium sulfate, and I will add antihypertensives.
Magnesium
And
sulfate in magnesium sulfate dose regime.
yes, ma'am. Intramuscular intramuscular regimen, Prichta regimen. It's 4 gram is given in 20% in 20% dilution. It's given intravenously at the rate of 1 to 2 gram per minute, and then 5 grams in 50% dilution is given in each buttocks as a loading dose. And then after assessing her, after looking for signs and for monitor for signs of magnesium toxicity, I'll continue magnesium sulfate maintenance dose, ma'am, which is 5 gram 50. Yes.
So you have started anticonvulsant. Apart from that, anything else you
Yes,
wish to give her till her
anti-hyper.
delivery or even after her delivery?
Ma'am, it should be given 24 hours following delivery, or if she land up in eclampsia, after 24 hours, till 24 hours after her eclampsia, ma'am, convulsions, whichever is greater.
You have not said anything about antihypertensive therapy. She is having
Yes.
blood pressure of 160 and 110.
Yes, ma'am, I mentioned it, ma'am, anticonvulsants, and after that antihypertensives.
What antihypertensive? Whether
Ma'am,
she was taking any antihypertensive before this visit?
uh, yes, ma'am. Actually, she was given her first dose in Women's Hospital Gadchiroli, ma'am, before she was referred to our tertiary care center. There she was given uh, lobetalol, ma'am. They have given oral dose, and they have referred to our facility, ma'am.
Oral labetalol, how much?
They have given 200 mg lobetalol, ma'am, single dose, and they have
So that
referred.
that means it was just before the referral. Before that, she was not taking any antihypertensive.
No, ma'am, she was not taking any antihypertensives.
You had mentioned that she had 4 visits in the third trimester,
Yes,
but
ma'am.
uh, I think you must have asked that what was the last visit before this particular visit when she was referred to you.
Yes, ma'am.
Before
I
that, even if she was having 4 visits, but the distance, the frequency of visit, you should be knowing exactly. So that in the, because it is a disease of the third trimester, and rather it is disease of the late third trimester. So
Yes, ma'am.
what was the time of visit? So earlier visit at what gestation? that can guide you that whether she was, and since when she was having edema. You have only given only one complaint that she has came to you with complaint of headache,
Yes, ma'am.
amenorrhea 9 months and headache. There
Yes.
should be some more relevant things in the presenting history regarding that. At present, you are on examination. You said that she was having edema on the feet, and any other feature also she can have. She has not informed about any previous blood pressure abnormality. So those things also should be, at least about the edema could be mentioned in presenting complaints.
And
Yes,
one
ma'am.
more
I
thing,
have
Dipti.
mentioned about the presenting
Mat-
complaints, ma'am. 10 to 15 days, since 10 to 15 days. It approximately 8 months amenorrhea. She had uh, pedal edema, ma'am, and it was gradually progressing from ankles till knees. And at around 8.5 months amenorrhea, she had complaints of headache.
Okay. And Dipti, one more thing. Your patient period of gestation is not corresponding with the with the fundal height.
Obstetric examination, yes.
है ना?
Ma'am,
So is there what are the potential complication of preeclampsia in mother and in fetus?
yes, ma'am. Complications, immediate complications in the antenatal period can be eclampsia, any accidental hemorrhages. She may land up in preterm labor. Patient may land up in preterm labor, and they and associated HELP syndrome. She may land up in HELP syndrome, pulmonary edema, and liver features of liver failure, and there may be decreased urine output.
Deeply take the hint of your examiner. She is asking the potential complications. We
Complications.
had asked you potential complication immediately, asking after the matching of the abdominal clinical finding and the gestation age. So you have to be smart enough to catch that she is about to ask you about the fetal growth.
Yes,
She wants to
You
know
have told
about the
about the
fetal
maternal
growth. She
complication. What
wants
about
to
the fetal?
know about the IUGR.
Hmm.
yes, ma'am.
Okay.
So fetal complications she wants to know, and not the immediate
Ma'am,
complications. That can be ongoing complications also. So
yes, ma'am.
IUGR can be an ongoing complication, and it is being evident by your clinical examination that patient is having 32 weeks of gestational age corresponding, while she should have the
30.
36 weeks or at least 30, 35, 34 weeks size. So this
Yes,
is there, and you have not told about the flank fullness. So you have not told about the estimated fetal weight. So we are here clueless that whether the baby is having IUGR
Compromised
or
or
not.
not? Yes.
Yeah.
That is why I told you in your provisional diagnosis was complete or not, because your finding was not matching. That is why.
yes, ma'am.
Okay. How do you assess the fetal? How you will do the fetal monitoring?
Ma'am, firstly, I'll ask the mother regarding her how is the kick count, and then I'll do non-stress test, and biophysical profile, and ultrasonography, ma'am.
How frequently you will do the biophysical profile?
Ma'am, biophysical profile is done twice weekly, ma'am.
Twice weekly.
Yes, ma'am.
Okay. Okay. Dipti, can you
One,
tell what are
one
the
more thing. One more thing here, that you have told that the mode of delivery, madam has asked about the mode of delivery. And you
Yes,
said, according to the bishop score, I will go for the termination of pregnancy by induction with
ma'am.
cervical ripening. But not only the maternal condition and bishop score is the key factor for deciding the route or the
Yes,
mode of
ma'am.
the delivery. The
Yes,
fetal condition is also important. If everything is all right, she is having good pelvis, she is having good bishop score, inducible, but the fetal condition is compromised.
Yes, ma'am.
In that situation, you need to go for
Termination.
the
Cesarean
the
section.
another, yeah, cesarean section. So you should have mentioned that thing, that I will like to do this thing, will confirm the fetal condition, will confirm the all these things, and then we'll go for the decision
Manage.
of the mode.
Yes, ma'am. Yes.
Okay.
Yes, madam, you can ask.
Okay. So after delivery, how you will, what will be the management?
Ma'am,
So
after
once the
delivery,
patient had delivered through vaginally or by cesarean route, so what
yes,
you will
ma'am. Ma'am, after delivery, I'll monitor the patient for any complications like eclampsia and postpartum hemorrhage, and then
why the
I'll
postpartum hemorrhage is more is common in a case of preeclampsia?
yes, ma'am. There, as there is a preterm labor, and there may be atonic PPH and traumatic PPH. She may land up in atonic and traumatic PPH. So,
And you are giving magnesium sulfate also?
yes, ma'am. Toco, as
Why,
it is
why she
tocolytic.
can, why she can land into atonic PPH is the question.
Yes, ma'am. As we are as we are giving her anticonvulsants and prophylactic anticonvulsant magnesium sulfate, and it is a tocolytic. It has tocolytic action also, so she may land up in atonic PPH.
Yes.
Say if you are this patient lands in antepartum hemorrhage rather than postpartum, you are monitoring the patient for labor, for vaginal progression, and suddenly you feel that fetal heart rate is being disturbed, patient is being pale, and you find out that there is antepartum hemorrhage, and you take the patient for cesarean. And you take out the patient when you took the patient for cesarean. At that time, after removal of the baby, you identify the uterus is bluish purplish and very relaxed. It is bag-like non-contracting uterus, and the color is purplish with multiple hemorrhagic points are being seen. What this is known as?
Covular uterus, ma'am. Uh,
So what you will do if you find such condition? The baby is out, the placenta is out, and the uterus is covular uterus.
uh, Ma'am, uh, as such, there is a no complication, even if there is covular uterus, ma'am. So I'll
What
go for
exactly happened in covular uterus? Why the uterus is bluish?
ma'am, as the coagulation profile may be deranged, platelet aggregation, um, thrombocytopenia may be there in a preeclampsia case. So there may be uh,
Hmm. What goes inside the uterine wall?
ma'am, clots.
So because of the presence of the clots in the uterine wall, what will happen
Uh, Ma'am,
post delivery?
proper contraction of uterus is not possible in such cases. There may be adherence,
So what?
placental adherence. Yes, intravasation, intravasation of blood.
So madam said power of finding is the covular uterus. So will you do the hysterectomy or will you leave the uterus? क्या करोगे?
Ma'am, there's no need for hysterectomy as such in case of
Yes,
covular uterus, ma'am.
yes, right.
And uterotonics uh, during during section we can add uterotonics, And
She is a case with hypertension. What uterotonic you will like to give her?
ma'am, oxytocin,
Oxytocin,
How
how
much?
much, by which route?
ma'am, oxytocin is given to 10 to 20 units in 500 ml 500 ml fluids through IV route, ma'am. At the rate of 60 ml per hour can be given.
And it can be given even intramuscular. In
Yes, ma'am.
AFPSL, usually 10 international unit we used to give intramuscularly. It can be given by IV infusion as well. In the
Yes, ma'am.
cases of PPH, 60 ml per hour may not be sufficient, and you have to see about the fluid management as well because your patient is hypertensive, and you
Yes,
have
ma'am.
to see about the complications of fluid transfusion. So you need to maintain the fluid balance. You
Yes,
have to
ma'am.
avoid the pulmonary edema.
Yes, ma'am.
One more thing I wish to like that clinical pallor. Have you mentioned how much pale she was? What was the clinical pallor status during examination?
Yes, ma'am. I mentioned it as there was no paler. There was no paler on examination, ma'am.
Patient was not pale. She was
Yes,
not even
ma'am.
having mild pallor. Okay, okay. So especially if the patient is more pale and having hypertension, then the situation become the furthermore poor.
Yes,
And
yes, ma'am.
you need to give. So what apart from the, if the oxytocin alone is not working, what else you can give for
Ma'am,
management of PPH?
yes, ma'am. Ma'am, I can go for uh, misoprostol per rectally 1000 micrograms and intra IM or intramyometrial uh, carboprost can be given. And if then also there is no tone, then I can go for carbitocin.
Okay, okay.
Yes,
Madam was asking about the postpartum monitoring. So say if she is not having the postpartum bleeding, everything is all right now. And the
yes,
patient, how you will monitor a patient in the postpartum period? Say she is day one post delivery.
yes,
So
ma'am.
at that time and later on,
Yes, ma'am.
what will be the points for monitoring of that patient?
Ma'am, I'll monitor regarding the signs and symptoms. How are her signs and how? What are the symptoms, and is there any progress of symptoms? And her input output charting. I'll be monitoring her input output charting. For fluid restriction, I'll restrict her fluid intake, and I'll monitor her BP readings regularly every 4 hourly, and um then her blood and urine investigations, blood investigations I'll do, um,
So
and
will
I'll
you
keep her
repeat
on.
her investigations and during the postpartum period? You said antenatal time you will do all the CBC, LFT, KFT, right? So will you
Yes, ma'am.
repeat this investigation during the postpartum period?
Yes, ma'am. Uh, whether they are whether the parameters are increased or decreased, I need to monitor the profiles. So I will do the investigations even after delivery, ma'am.
But if the previous investigations were normal, then also during
Yes,
the
ma'am.
antenatal time or CBC, LFT, KFT were all, as in your case, only the BP was 160, right?
Yes, ma'am.
But rest other investigations, if they are okay, so will you like to repeat them again during the postpartum period?
Yes, ma'am. Sometimes there may be uh, hypertension even in a postpartum period, and um,
Okay. How frequently you will monitor the BP?
ma'am, 4 hourly monitoring.
No, see, a postpartum care of a preeclampsia patient is like immediate or late, right?
Yes,
Immediate may how
every
frequently you will
every
do her BP monitoring?
every half an hourly, ma'am. BP
Every
pulse.
Every
her
15 minutes in the first 1 hour, right? And then later you will do every hourly.
early.
Okay. And then you will look for the sign and symptoms of impending eclampsia.
Eclampsia. Yes,
Okay.
ma'am.
So you will continue the magnesium sulfate.
For 24 hours.
And
In
will you
case,
continue her antihypertensive drug?
yes, ma'am. I'll put her on antihypertensives too.
What is your target BP
Ma'am,
post delivery?
it's 140 by 90 millimeters of mercury, ma'am. Less than
As
equal to 1. Yes, ma'am.
Like say
yes.
if your patient is having BP of 200 by 120. Say one patient is having BP of 200 by 120. The another patient is having BP of 160 by 110. The third one is having BP of 150 by 100. Uh, are the target BP of all the patients will remain same, or the target BP for every one of them has the different targets?
Ma'am, it should be individualized, ma'am, target BP too, because in the first patient there is if
Because you said 140/90, that's why I am asking.
yes, ma'am. Ma'am, it should be individualized, ma'am, because sudden decrease and the more difference will lead to cerebral uh, isch- uh, bleeding, increased chances of bleeding, ischemia will be there, ma'am, and she may land up in sudden hypotension. So I'll individualize it, ma'am, based on her BP readings.
And you said that you will individualize. So the madam's question is still incomplete. So what should be the target BP? Like 160, 110 के लिए क्या target BP रहेगा? Is it should get down by percentage, or it should get down by 140/90?
Ma'am, it should be between 140. Systolic BP should be 140 to 160, and diastolic BP should be maintained between 90 and 110.
But
Madam want to clarify her?
Yes.
But your patient BP was already 160. But if the target BP should be less than that, you said in a range also 140 to 160 systolic, है ना? So
Yes,
that is
ma'am.
right. Okay. So what are the other care you will give her during the postpartum?
Uh,
Apart from monitoring her BP, watching for signs and symptoms of impending eclampsia, you will continue the Maxel, you will continue the antihypertensive drug based on her BP records. Any
yes,
other thing?
ma'am. Fluid restriction.
Yes. When you
Her,
will discharge your patient?
uh, ma'am, after her BP readings, become within the
Her
range of
BP records are normal after 2 days. Then you will discharge her?
no, ma'am.
Hmm?
At least a 48 to 72 hour period monitoring should be there, ma'am.
Only 72 hours.
Uh, ma'am, 96 hours.
When you will call her for the follow-up?
Ma'am, she can be called we- uh, within a week, every week.
Every week.
Yes, ma'am.
And what you will do in her follow-up visits?
Ma'am, I'll uh, I'll measure her. I'll measure her BP recordings, and I'll go with urine examination, repeat urine examination, and her blood counts, ma'am.
See, if you don't discharge your patient before 1 week, right? Minimum 1 week, you need to keep them. Okay. And
Yes.
what is the contraceptive advice you would like to give her?
Uh,
Because your case is a severe preeclampsia. Is there any contraceptive agent or drug which is contraindicated?
yes, ma'am. OC pills cannot be given in these patients.
So are we
Oral
giving
contraceptive.
immediately post delivery?
Yes, ma'am.
Are we giving OCP drug immediately post delivery?
No, ma'am. We can advise her barrier contraceptives.
Madam's question was about the contraindication. There are few contraceptives which are contraindicated in severe hypertension. What are those?
Um,
6 weeks, till 6 weeks, she will not need any contraceptive. But what are the contraceptives which are contraindicated? Number one. Number two, not only if you can have your patient with the organizers can just point it out if we are getting late for
Yes,
the
yes,
other
ma'am.
lecture.
We are running late by 5 to 10 minutes, ma'am.
Okay, okay, okay.
So I think we have given the suggestions to the student and we should wind up now because everybody must be very eager to listen to Girija Wagh madam.
Yes,
And
yes.
Deepti, you should have correct your probable diagnosis. You should also give some differential diagnosis that these things I have to rule out for reaching for the final diagnosis, and you have
yes,
to give the due importance for the history, what points you have just left, and
yes,
about the fetal monitoring, the fetal part.
yes,
Okay.
ma'am. Okay, ma'am.
Okay. Thank you
Thank you,
very
ma'am,
much.
for
Ma'am,
concluding. Thank you, Jyoti, ma'am.
Thank you.
thank you,
Yeah,
Dr.
yeah.
Dipti, for your
It
apt
was
presentation. And
it was
thank you,
very nice.
Dr. Jyoti ma'am and Dr. Anita ma'am for the detailed and thorough discussion. Thank you very much.
Yes, thank you.
Now
Really, it
we
was
will
very
move to our
nice.
next session.
Dr. Dipti also really very nice, Peter. And
Thank
Dr.
you.
Jyoti, thank you.
Thank you, madam. Thank
Dr.
you for
Anita, thank you
inviting
very
for
much.
Please
the
kindly
Thank
run
you.
the presentation.
Yes, ma'am. Yes, ma'am.
Please stop sharing. It was amazing.
So our next session is Pearls of Wisdom. And the presenter is very renowned gynecologist, Dr. Girija Wagh ma'am. The chairpersons for this session are Dr. Madhuri Dabde ma'am and Dr. Rohan Fernandez sir.
Hello, Dr. Madhuri. Hello, Dr. Rohan.
Yeah, hi.
Yes,
Dr. Madhuri ma'am is a practicing gynecologist at Nagpur since 30 years. She's the past president of Solapur OBGYN Society. She's a recipient of Best Society Awards at national and state level during her presentation tenure. She received many awards for work done in the society and medical field. She received the Sri Ratna Puraskar, Agrani Puraskar by Lions Club and Sharat Pratishthan Puraskar. Welcome, ma'am.
Thank you.
Dr. Rohan Fernandez. He is a MBBS, MS, and DNB OBGY, and he has completed his short course on basis and advanced laparoscopic and hysteroscopic training program at Sangli. He secured the first place in TYSA OBG Young Scholar Award by Torrent at the West Zone in Mumbai. He is the first gynecologist in the Goa to perform the major endoscopic procedure in Director of Health Services Goa. He has successfully performed over 60 major laparoscopic procedures in South Goa District Hospital. Next slide, please.
yes, ma'am.
He has conducted numerous health camps for screening of cervical malignancies and pre-malignant lesions. He held numerous health talks on varied topics in different populations. He has indulged and actively participated in various CME programs in Panji Obstetrics and Gynecologic Society and Madgaon Obstetrics and Gynecologic Society. And his goals are to learn the nuances and master the art of endoscopic surgeries. Welcome, Dr. Rohan sir.
One thing I will tell you, Both are
And
very good
Dr.
in
Surekha,
social work also. Surekha, they both are very good in social work also. They have invited for the Garbhavati Garbha Sanskar. Both are really very good and very good having this telling, very good telling of the patients also. Very small things and practical tips.
Thank you, Sushma.
Thank you, ma'am, for being so generous.
Yeah.
Okay, continue, please.
hand over to you, Chairperson.
Rohan?
Yeah, ma'am.
Yeah. Shall I talk or you are going to talk about Girija madam?
No, ma'am. You should do the honors, please.
Yeah. Dr. Girija Bagh. She's a professor and HOD of Department of OBGYN, Bharati Vidyapeeth. A senior consultant in Cloud9 and Apollo Hospital, Pune. Faculty professor in OGASH International Expert General Coordinator. Chairman Medical Disorders in Pregnancy Committee, FOXY, 2012-16. And Vice President, India Chapter Justosis since 2014. A member and Governing Council of ICOG, Joint National Secretary, FOXY in 2010 and elected as the Vice President, FOXY West Zone, Assistant Coordinator and National Eclampsia Registry, Member and Central Supervisory Board of PCPNDT Act, a National Mentor of Laksh and GOI. I don't know what is it. Sorry, madam. The Anandi Bai, she has received Anandi Bai Award for the excellence in medical services. Girija madam, she's apart from this introduction, she's a great teacher, and I had opportunity many times. I have listened her lectures, and really she's a great teacher. Over to you, madam.
You should stop sharing.
Hello, good evening.
Hello, Girija.
Good evening, Girija madam.
Good evening.
Welcome to all. Welcome, Chairperson. Welcome, Girija.
Hi, good evening. Can you just give me the rights to share my presentation, because it's saying host as disabled participant screen sharing.
Corona people, please manage.
Yes, ma'am. I did it. Please check once.
Hi, good evening, everybody. I hope you are able to see my screen.
Yes.
Yes, very much.
Okay, thank you. Extremely grateful to the Nagpur Society for giving me this opportunity, and I was enjoying the case discussion thoroughly. It was such a wonderful session. I had actually shared this with my postgraduates as well. I hope they have attended this. Unfortunately, I didn't get time to check whether they were there or not. So it was just through my OPD that I decided to connect to you today. And thank you, Pragati, for giving me this particular topic, because I love to always speak about, screening for HDP. Because while the world is talking about the impossibilities, I feel that everything can be possible in our country, where we are such senior gynecologists, such sincere doctors, dedicated doctors, and most of our touch comes from the personal connect with our patients. And if that is doable, I think we can really control this problem. And in my experience, that has been in the University Medical College, as well as my private and corporate practices, I have seen that if you are there with your patient, you can really make a difference. Whatever complications come to you are usually, like whatever I experience in the university college, are usually the ones who have not received optimum antenatal care. So when we have such youngsters, as we had wonderful presentations today, and I was much impressed by Dr. Rohan's CV as well. So I think there is definitely a good promising future for the women of this country, health-wise, as we are always, indulging. And congratulations, Nagpur Society, for constantly doing this endeavor of connecting through education to everybody. So I'd like to quote Albert Einstein: to raise new questions, new possibilities, to regard old problems from a new angle requires a creative imagination, and it really marks the real advance in science. And that is what we have to constantly keep on doing. Thank you for that wonderful introduction. I would like to tell you the long form of GOI is Government of India. So I think there was a little hitch while introducing that. So today we are going to look at prediction of HTP or screening for HTP, and it wouldn't be complete if I don't dwell upon a little bit of prevention also. So what is HDP? Something that we must understand, because much of our focus has been on preeclampsia, especially the early onset type, naturally so, because it can be very destructive for the baby as well as the mother. But sometimes I feel that a lot of attention is given to that component, and many a times women may just get neglected, and therefore we should be focusing on the entire conglomerate of HDP, which is a pathological conditions that have raised blood pressure as a presenting finding, and they are representation of much more not going well underneath. So therefore, whenever you have a woman who comes to you with a blood pressure abnormality, then you must always consider to find out what is there underneath her. There may be problems. Now, you are definitely unfortunate if you have a patient coming to you completely normotensive and then throws a convulsion or lands up in a complication. And later on, you come to know, oh my goodness, she is one of the HTPs. But then those are a little rare, and that gives us definitely a little respite. But whenever you have an abnormal blood pressure, be on guard, and that is your point of start for looking for the patient. Now, whenever we are looking at HTP gestosis, this is the entire plethora of the conditions that are there. And today, with women choosing to have babies late, we also have chronic hypertension very commonly being presented in our clinics. And this chronic hypertension would usually have a blood pressure of 140/90 before 20 weeks of gestation. Women will be older, obese, or black. And they also have an increased risk of preeclampsia, fetal growth restriction, CHD, and chronic hypertension definitely has a higher risk of adverse outcomes. So one of the most important screening components, if you ask me, would be the clinical assessment of the woman when she comes to you for their antenatal care or prenatal counseling or for preconception counseling. Measure her blood pressure, even if she's young, and that itself will give you a huge clue. Then comes the gestational hypertension, where a woman will have hypertension after 20 weeks of gestation. However, there will be no proteinuria. Now, this is that particular segment of this entire disease, which has 40% potential of turning into preeclampsia. And then you would have the late onset preeclampsia and the early onset preeclampsia, where you would have proteinuric hypertension occurring before 32 weeks of gestation. So before 34 weeks of gestation, to be more specific, if there is proteinuric hypertension, then it is early onset. While if it has occurred after 34 weeks, you see there's hypertension, there's proteinuria, then that is late onset preeclampsia. And then we also have an newer thing which is happening there, where you have an intrapartum as well as a postpartum hypertensive disorder, which isn't always a residue of all these diseases before. It can be a de novo occurrence, which has occurred for the first time during this particular pregnancy. So therefore, looking at this postpartum aspect is also very, very important. So your vigilance for your patients does not stop. As I mentioned, just recently we had a mother who had come to us in labor, and at 3 centimeter was very insistent that we do a C-section where there was no indication. And we therefore decided, and she did not opt for epidural analgesia either, despite being offered. So we were monitoring her on injectable painkillers and birth companion and everything in our university hospital. And suddenly, after about an hour or so, she was just between 3 to 4 centimeters, and she threw a convulsion. Now, at that time, we really didn't know what it was. Patient had not given us a history. This we came to know in retrospection. that she also had a seizure disorder priorly, which she had hidden from her family, and that was never told to us. She was not taking any medications. That was one component. But after delivery, she required intubation, ventilation, C-section, and all that typical thing. But after delivery, we found that she had all the labs of preeclampsia coming positive with proteinuria. So you can understand that this is a disorder which can strike women anytime. And most of us are, on that brink where there is a lot of volcano brewing down there under the surface. And 20 weeks is the time which especially helps us to differentiate between all these things categorically. And proteinuria definitely helps us in helping to classify preeclampsia. Now, sometimes when you have women of chronic hypertension, or if you have women of gestational hypertension, and when you feel that it's really not up to the mark, there are issues, you can consider looking for proteinuria by doing the usual creatinine ratio. And I request Dr. Bhakti Gurjar to kindly mute yourself, my dear.
Please mute the other.
Yeah, no problem, no problem. Sushma, thank you so much. Sushma is my very dear friend, academically active, and she's doing so much of social work. I feel very proud of her. So now, so when we look at this entire vista of HDPs, you can see that whenever the blood pressure is 140 or 90 or more, it is preeclampsia, which can happen in women who have proteinuria, acute kidney injury, transaminitis, CNS diseases, thrombocytopenia, or uteroplacental dysfunction. And here I would like to tell you that clinically, always be on watch on those women who are normotensive, but who have a fetal growth restriction. So whenever you are doing a growth scan or you're doing a clinical assessment, and if you find that there is a growth restriction, always try to look for color Doppler changes. And if there is any uteroplacental insufficiency seen, many times we find that in our women, they will start with a fetal growth restriction with a uteroplacental insufficiency and then gradually develop preeclampsia or HDP. So these also women require an attention to be given. There's a condition which is called as a white coat hypertension. When they come to the hospice, they will have a blood pressure rise, and they are 8% risk of developing preeclampsia. So these are the ones. So your clinical screening itself can help you in identifying and risk tagging these women. Transient hypertension can be there, that the blood pressure comes around 150-90. Later on, she just follows something. You say, come for follow-up, you don't have any proteins, let's see. And then she just takes a little lifestyle changes or something. Next time she comes, her blood pressure is 130/80. But keep a watch on these women because 20% of them are likely to get into preeclampsia. Gestational hypertension, 25% risk, and chronic hypertension also nearly have 25 to 40% risk has been also been found in few studies where it is possible that they will develop preeclampsia. So the question comes, what do you want to predict or what do you want to screen? Now let us look at this particular condition. As I told you, chronic hypertension happens to be an important part when you identify it. Abhi, what will be my approach in a woman who has come to me with chronic hypertension? Who is the woman whom I can call chronic hypertension? Now, naturally, chronic hypertension cannot be predicted. But knowing that the woman has chronic hypertension, you can risk tag her and try to find out that, yes, do a proper surveillance, do some preventive things wherein you could avoid her transiting into preeclampsia. So it must be looked for as the incidence is increasing, and look at the newly defined criteria for diagnosis of hypertension by the ACC and the American Heart Association. And this is going to really help you clinically. And this is the category of blood pressure is written on this side. And you can see the systolic and the diastolic blood pressure and the comment. So 120/129 millimeters of mercury is called as elevated blood pressure, and the diastolic blood pressure, so 120/129 millimeters of mercury and less than 80 is taken as normal, while 130, so if the blood pressure is 130, 129 or more than 120 or more, then this is taken as elevated systolic blood pressure. Stage 1 hypertension is 130 to 139 and diastolic of 80 to 89 units of mercury. So just imagine, remember your manometer is so very important, which has an increased risk of preeclampsia, gestational hypertension, small for gestational age babies and indicated preterm births. Stage 2 hypertension is more than 140, more than or equal to 140, more than or equal to 90 systolic and diastolic respectively. And these also have similar risks and adverse outcomes also are associated. And therefore, looking at blood pressure itself is a very, very vital screening tool for these disorders. Now, coming to gestational hypertension, remember, blood pressure rise after 20 weeks has to be properly measured only by doing proper blood pressure measurement. And during pregnancy, it is why? So basically, blood pressure measurement should be done in a proper way using the correct position of the patient first. She should be comfortably seated. Then the cuff size has to be normal. And her arms have to be at her forearms, have to be, the mid arms have to be at the level of her heart while you're measuring. They cannot be up or down somewhere while you're measuring the heart. And you can consider also taking, now if you don't have a mercury manometer where you can use the Korotkov sounds, you can consider using the mean arterial pressure measurement by using 2 aneroid machines, maybe at the same time, or one machine and immediately after that taking on the other arm. And you can just go on to this link and try to put in your values and understand the risk calculation of this patient. So whenever we are looking at this particular blood pressure, which is up there, there are so many other types of presentations which we can have. Patient who has excessive weight gain. I'm going to come at the end for this. Maternal risk factors, swelling or edema, feeling of being unwell. All these patients may have normal blood pressure, but they may be having preeclampsia. So when you're clinically looking at this patient, these things matter. Speaking to your patient, asking her questions are important. Because below this surface, which everything seems to be quite hunky-dory, there can be problems such as HELLP, SGA, seizures, insufficiency, and multisystemic involvement, which can lead to various complications. And you have to appropriate take help of using biomarkers, surveillance, and laboratory and imaging. Otherwise, if you are not able to do these things, you may unnecessarily take these patients into complications such as eclampsia, women requiring a severe intensive care unit. You can see here that there is a woman who is on life support and they would require an intervention to monitor them, and they can land up in PRES, which can be a permanent morbidity for their brain function. So therefore, looking at these things is very, very imperative. Now, prediction or screening components, if we see, simpler would be, is there going to be, so one component is there going to be preeclampsia in this gestational hypertension or chronic hypertension patient? Simple. Why this is simpler? Because you have one disorder and you have to just keep a watch on her whether she's going into preeclampsia. But is there going to be preeclampsia in this pregnant woman? Is too much to do, because screening all pregnant women, how are we going to do that? One is BP, but there's other thing also which I'm going to speak to you, that is gestational gestasis score, which can help you in trying to do clinical risk stratification. And the third component is there going to be preeclampsia in this delivered woman? So for that, you definitely require to have a very closer vigilance. So if you ask me, screening gets encompassed in all these 3 components of prediction, as I have mentioned. Now, a lot of awareness has been accrued after looking at the pre-study results, which were published in 2018, where they had done a complete recce of various components of diagnostic accuracy of early screening of preeclampsia by the NICE guidelines and a method combining maternal factors and biomarkers. And you can see what was their experience here. So when they saw that maternal factors, uterine artery PI, PLGF, were compared with maternal factors, uterine artery PI, PLGF plus mean arterial pressure, it was found that the sensitivity of this improved quite significantly, and therefore go all out if it is necessary to screen women. However, we understand that doing PLGF in all patients is a little out of reach, and you can consider maybe to do it for those niche patients where you have identified by clinical assessment that probably these are the women at risk of developing these problems. And therefore, you would definitely do a good sort of a service to women, even if you look at maternal factors plus uterine artery pulsatility index. As you can see here, will give you a detection rate of nearly 62%, while maternal factors versus maternal factors plus PLGF would be about 60%. So don't get worried if you don't have an access to PLGF. You have yourself who can clinically assess these patients. So now evidence has always suggested the target for first trimester screening. And this should be, should be severe preeclampsia leading to preterm birth rather than all preeclampsias. Because there are two reasons for this suggested change in clinical practice. Because aspirin is more effective than previously thought in reducing risk of preterm preeclampsia. And the second reason for the performance of first trimester screening for preterm preeclampsia can be improved substantially if the current method that relies on maternal factors alone is modified to include the measurement of biomarkers. So SPREE has demonstrated that screening for preterm preeclampsia by a combination of maternal factors, mean arterial pressure, uterine artery PI, and PLGF rather than the NICE guidelines would be able to double the detection rate at the same screen positive rate. But I already told you how even doing a proper clinical assessment would help. And this would help because it's not only that you're going to screen for severe early onset preeclampsia, you also want to screen for the entire conglomerate, and because you are concerned about the mother's health as well, and not only about the baby's health. So this was a model which was suggested by the AGOG in 2020, the fetal medicine foundation triple test, which has detection rates of 90% and 75% for the prediction of early and preterm preeclampsia, respectively within a 10% false positive rate. And you can see the percentage of detection rates here, and you can see the false positive rates in 10%. But you can see what all has been compared here. You can absolutely see in the first line, just the maternal factors have been looked for. And then you can see that here, maternal factors for plus mean arterial pressure. Here, maternal factors plus uterine artery pulsatility index. Here you can see maternal factors, MAP plus uterine artery pulsatility index has a very, very nice prediction level for preeclampsia less than 32 weeks, preeclampsia less than 37 weeks, and preeclampsia more than or equal to 37 weeks. So this also is a wonderful combo that we can have, while the FMF triple test adds PLGF to it, and it has found this particular improvement. I would still stick to this for our patients because PLGF can sometimes be at large, and if you are there as a clinician, you can definitely hold good to identify these patients. So this is the proposed algorithm of management when patient comes to in the first trimester. Look at the maternal factors, and here, instead of using the NICE guidelines, you can use the Gestosis score, which I'm going to discuss as we go by. And then the MAP, uterine artery PI, PLGF, and risk evaluation of preterm preeclampsia can be done. If she comes to be a high-risk mom, you can consider giving her low-dose aspirin, and low risk if she's so no aspirin. However, in the second trimester, if you're doing a quadruple test, or most of us in our country today, we are doing the triple marker test, that is the double marker test where you're doing the uterine artery PI, good enough, or you can combine it with a quadruple marker test where you are doing a PLGF and an S-FLET1. and then do a risk stratification. That's what this particular algorithm proposed by the FMF says. And then you stratify them into high risk and low risk with a high level surveillance, where here there'll be a standard surveillance to the patient, and at third trimester, again do a risk assessment by doing the MAP, PLGF, FLET1 and risk evaluation for preeclampsia, and low risk standard surveillance, high risk here would undergo and or induce labor. Here, rather than going in for PLGF in these patients, I would rather choose to look at their weight gain charts. And we can also consider doing a uterine protein creatinine ratio itself. And that can help us in doing this risk stratification if we don't have a PLGF here. So therefore, this all came based on the biomarkers. There are biomarkers which are used in the first trimester, such as the PLGF, part of combined first trimester screening protocol for preeclampsia, typically called as the triple test, PAPE, and the endoglins. In the second trimester, you can use the PLGF, the SFLET1 PLGF ratio, or the glycosylated fibronectin as a point of care test. And we all know that the hypoxic placenta gives rise to release of certain products. And these products, especially such as the SFLET1, are known to be the byproducts of cellular destruction, which if increased are going to be giving you an inkling that probably things are not going very well. And if the PLGF is very low, that is also a marker of an abnormal possibility of preeclampsia occurring. Now, uterine artery pulsatility index is a very valuable marker which can be considered definitely at 11 to 14 weeks of gestation as part of first trimester combined screening for prediction of early preeclampsia. But in your high-risk moms, it's always a good practice to keep on evaluating it at 16 weeks, 19 weeks, 24 weeks. Sometimes women would come up with this resistance later on, and therefore you can use your antenatal period for such kind of a surveillance. It requires specific way in which you place the probe and sample the uterine artery, and the mean PI of the right and the uterine arteries to be then calculated, and the increased resistance to blood flow, that is the high mean uterine artery PI, more than the 95th centile for that particular gestational age, is caused as the increased risk of preeclampsia. And definitely you have to have proper skills to examine this. And this has been published in the 2018 guidelines. So this is how you are seeing the uterine artery Doppler pulsatility index done at the time of doing NT scanning, where 0.97 is showing a nice, wonderful diastolic perfusion, while the high uterine artery PI of 2.37, which is taken as high risk for preeclampsia because it is more than the 95th centile for this age, you can see that the baseline diastolic perfusion is not up to the mark, and therefore this placenta is going to undergo definitely a problem as the pregnancy goes by. So the cutoffs gestational age-wise are quite specific. If you look at them, 11 to 13 weeks in a transabdominal scan, 2.35 and 3.10 on transvaginal would be the mean PI on the 95th centile. But for the second trimester, somewhere around 23 weeks, this is the time usually we do a fetal 2D echo for the baby. That time it would be 1.44 and 1.58 transvaginally. And in the third trimester, it's usually a transabdominal scan done at 30 to 34 weeks, where 1.17 would be taken as a PI. So history-based screening for preeclampsia has been in place for a long period of time, and that is where we have always been practicing in our practices as well as while we are teaching our students. And the NICE guideline in 2019 mentioned that pregnancy women with one high risk factor or more than one moderate risk factors are advised to take 75 to 150 ml of aspirin daily from 12-week gestational age until the birth of the baby. And these are the very famous moderate risk factors and the high risk factors under the NICE guidelines. ACOG in its 2020 guidelines recommended history-based screening, but more maternal risk factors have been included, such as pregnancy as a result of ART. And this has been associated with higher incidence of preeclampsia. Now we have in our center published data under the REVAMP study, which is the research exploring various aspects and mechanisms in preeclampsia. And this was an ICMR project under the Center for Advanced Research of Preeclampsia, which was conducted in I happen to be the principal investigator of this study. And there are certain excerpts that I have gotten to you from this study where maternal characteristics of non-preeclampsia and preeclampsia women were compared. And we had gone and collected blood at various points in times during their gestational age. And it was found that women with preeclampsia were older professionals and educated nulliparous. And percentage of women who conceived by assisted mode of conception were higher in the preeclampsia group. And this is something, therefore, taken as a risk factor for these women. So as I mentioned, these were the time points when the women's bloods were collected at 11 to 14 weeks, 18 to 22 weeks, 26, and at delivery. And the higher body mass index, systolic and diastolic blood pressure in preeclampsia was found in all time points across gestation. So you can understand how it is important to measure the blood pressure of women correctly. And higher percentage of women in preeclampsia group delivered by C-section. Some other clinical parameters which were of interest were also higher levels of TSH were found at 11 for 14 weeks and 26 to 28 weeks in the preeclampsia group. So continued surveillance for TSH also would be a rational based on this observation. And I must tell you that we have a data of now nearly over 1,500 such women who have been screened for this preeclampsia at various time points. Now let's come to the parrot study, because this is something which has recently been spoken about. And this is a study which definitely has a good credential, where patients were segregated into normotensive or mild hypertension, moderate hypertension patients, and severe hypertension patients. And these were enrolled in an active arm, and integrate additional information from PLGF test was suggested, and this was what was found. So whenever you find that the PLGF level is less than 12 picograms per ml, this was taken as highly abnormal in these normotensive and mild hypertensive women, and then it was suggested to check their preeclampsia labs, urgent further investigations, fetal ultrasound for growth and Doppler. If normal, repeat Doppler weekly, CTG from 26 weeks, and daily review was recommended, because PLGF less than 12 is taken as a critical level, which can cause complications, and that can help us in all these conditions where we really do not know where, in what direction this patient is going to head. Now, if the levels of PLGF were found to be more than or equal to 12 and less than 100, it was taken again as an abnormal. Do the preeclampsia studies. She needed further investigations, as mentioned here, but then the surveillance could be a little relaxed. And then if it is more than 100 picograms per ml, then you would still check her PET labs because she has hypertension. But then this is a green zone where you can do home-based management even in these conditions and take a call based on the clinical assessment of this patient. So here, PLGF has been used to segregate these things. Just give me a minute, just a moment. So if you look at this schematic for parrot Ireland hypertension, NICE Institute of Health and Clinical Excellence study, these were women who were between 20 to 36 plus 6 weeks with suspected preeclampsia, and they were triaged as per current randomization of their maternal hospital. So the PLGF arm and the non-PLGF arm. And as I told you, the levels, depending on what levels came, they were segregated. And in the non-PLGF arm, they were managed according to the clinical protocols that we usually follow. And the post-delivery review of the chart and collection of the outcome data was done, and this was published in the BMJ 2019. So this gave us an insight that this would definitely be a wonderful way in stratifying this patient so that you can identify how long you can continue this pregnancy and when you would really want to intervene, just looking at the PLGF level. Now, further on, there was another such kind of a pragmatic RCT which was done, wherein they tried to look at women with chronic hypertension. And they also proposed that even if you have a patient of chronic hypertension or gestational hypertension, please give them antihypertensive medicines, because the moment you give them these antihypertensive medicines, you will definitely be able to reduce a lot of complications in these patients. Another way of stratification is by looking at the maternal echo. And I must say that in our country, in Tamil Nadu, all women during pregnancy, around 32 to 34 weeks of gestation, are screened by doing 2D echo in all mothers. Now, this maternal echocardiography is a valuable tool to stratify risk and can guide management and counseling in preclinical and clinical phases of gestational hypertension and preeclampsia, because there are definitely cardiac function changes and they can be morphology recognizable at an asymptomatic early stage. And these changes correlate with disease severity and adverse outcomes, especially if preeclampsia has known to have a greater impact on the heart than gestational hypertension, and changes are most pronounced in early onset and severe disease. Diastolic dysfunction and left ventricular remodeling are the key features of this cardiac modification. So if you have a patient, and this was a publication in 2016, where cases of gestational hypertension versus preeclampsia were stratified from 36 studies, it's a meta-analysis, a systematic review. And they found that if the lift well thickness is less than 1 centimeters, normal systolic function, and lateral ejection of 14 centimeter per square, then this was supposed to be a low risk patient. While if she had an increased left ventricular wall thickness, LVEF less than 50%, patient required intensive management, increased surveillance, appropriate medical therapy, expedited delivery, and echo-assisted fluid management in severe cases. Likewise, another component is delivery. Like, you must screen your patients and identify patient is having fetal growth restriction, you will go on continuing based on that. No, look at the maternal context. There can be a problem. And it was found through this Phoenix study, which was published in the Lancet, that it's always smarter to do a planned early delivery or an expected management for a late preterm preeclampsia rather than waiting her to get into complications and then delivering her. As I mentioned at the outset, postpartum surveillance, where BP monitoring and watch out for complications, at least 3 days in hospital monitoring is important. Continue antihypertensives. Hospital visit at 3 months postpartum is very, very important. If hypertension or proteinuria persists, appropriate referral and workup. Significant long-term cardiovascular risk exists, and this has to be told to the patient and educated about, and you can consider doing a postpartum echo. And annual follow-up and healthy lifestyle is extremely important. While we are doing this, this is one of my publications which is under now review, and this is using the high-sensitive cardiotroponin 1 as a marker for preeclampsia. And it has been found that this high-sense cardiotroponin done in the early part of the pregnancy or for risk stratification, whenever a woman presents with GHT, CHT, or any hypertension, can be a very, very valuable tool to help you in guiding whether this patient is at risk of developing preeclampsia and its complications. Now, how can you prevent this condition? Simple things: pharmacology, dietary, and modification of lifestyle. And low-dose aspirin has made a lot of change in our practices and has shown the problem with low-dose aspirin, however, is compliance issues, which has to be reiterated. Nitric oxide agents haven't shown any sufficient evidence to support. Low molecular weight heparin and others also have not really, like diuretics, progesterone, have shown insufficient evidence. While calcium is a very, very important prophylactic measure, wherein you can give in women like our country, where the calcium consumption is less than 800 milligrams per day through dietary sources, you are justified in giving 1.5 to 2 grams of calcium per day in divided dosages to these women. Nutritional supplements such as antioxidants, folic acid, magnesium, marine oil, and other PG precursors haven't shown any beneficial effect. But certain lifestyle intervention and diets such as resting 4 to 6 hours or 30 minutes per day, during the daytime has been shown to have no evidence. But currently there's a lot of talk going on about it, because exercise is another very useful thing, which is known to reduce plasma or triglycerides and inflammatory cytokines. However, evidence support was not there, but now it is there, and I'm going to show you at the end of my talk in just the next couple of slides. Dietary salt intake can be personal, reference, and no restriction. Energy and protein intake has no evidence to support, and garlic likewise has no evidence to support. Now, I always like to stress upon the protein content of our diet, because if you look at the FIGO guideline, it is said that every pregnant woman should consume 1 gram per kg body weight of protein throughout a pregnancy. And when we did any kind of an analysis of the women's food intake, food frequency charts, we found that these diets were hugely deficient in proteins. Because during pregnancy, the mom's blood volume increases by 50 to 80%. Her liver makes albumin from the protein she eats. Albumin is similar to egg white and pulls the fluid out of her tissues to help maintain the blood volume. And if the mom doesn't eat enough calories, her protein gets burned up for calories as opposed to being used to make albumin, and this causes a drop in blood volume. The kidneys think that the drop in blood volume is due to hemorrhage, and it produces androstenedione, and this results in high blood pressure, and mom, thinking salt is bad for high BP, starts restricting her salt intake. The kidneys try to resorb as much fluid and salt as possible to increase the blood volume, but because there is a lack of albumin and salt, the resorbed blood fluid leaks into the tissues, causing edema, rapid weight gain, and further increase in blood pressure, which results in preeclampsia. So to reduce the risk of preeclampsia, it is recommended that pregnant mothers consume 80 to 120 grams of protein daily and can use salt for testing. And these are foods which are very, very important to be consumed by mothers who have preeclampsia. Otherwise, you will have a story like this primipara, who is 21 years of age, delivered at 26 weeks with severe preeclampsia. And this is a picture taken after 2 days of delivery, where there is excessive edema, a sign of severe energy malnutrition, micronutrient deficiency, has ascites, pallor, facial and upper arm edema, as if she's drowning in her own waters. So embarking on a pregnancy with a setting of protein deficient diets and its consequences like kwashiorkor-like situation, further aggravated by pregnancy and its demands. And we have a lot of research on this below our belts: maternal vitamin D deficiencies, alter metabolic homeostasis due to vitamin D and unsaturated fatty acids, LC-PUFAs and all, which are published and well acknowledged. And therefore, nutrition, looking at holistically from all aspects, is extremely important to ensure that women have proper nutrition to prevent hypertension. So this is the famous HDP score that we always quote about, wherein you look at risk factors and stratify based on their value, considering age, maternal anemia, because these are very important in our country, PCOS, hypothyroidism, which have not been factored in the NICE guidelines, and chronic vascular diseases like dyslipidemia and excessive weight gain during pregnancy have been awarded 1. Likewise, GDM, obesity, multifetal pregnancy, hypertension 2, and risk factors, especially when we talk of pregnancy in the ART, especially by oocyte donation and surrogacy, there's straight gate 3. And it's found to be very feasible. Many of our friends are using it all over in their practices. And if the woman has a total score of 3, she's considered as high risk. So this can be an important thing, because biomarker-based surveillance is something which is really inaccessible to our patients. And therefore, this is an algorithm which we propose, screening protocol, which will include using the Gestosis score. And if she has less than 3 score, continue the standard vigilance and keep on looking at her through trimesters. If she has more than or equal to 3 score, then continue. She's screen negative for all these biomarkers can be considered, or you can just do a clinical vigilance and then continue giving her aspirin 100 to 150 milligrams, and talk about antenatal surveillance, means educate her about preeclampsia, dietary supplements, regular BP checkup, be alert for GDM, hypothyroidism, extra weight gain, and give her supportive therapy and correct nutritional guidelines. This was the evidence that I was telling to you, published in NEJM 2022. Moderate exercise of more than 140 minutes per week will reduce 40% of preeclampsia. If a high risk of preeclampsia, initiate aspirin at 16 weeks, even more than 100 would reduce 60% of preterm preeclampsia. Calcium intake 50% and timed birth 35% reduction. And this is an excerpt of the chart that I use in my practice day to day. You can see that the woman's, her own BMI based charting has been done, and she has been given a plan that your weight gain has to be along this particular line. But you can see that she started increasing her weight, and this is somewhere around 13 weeks. And this is the time that I sit again and talk about her nutrition, exercise, and everything, and try to help her that we need to take cognizance of these things. Always educate women and her family about the early warning signs and various reasons for which they must come to you immediately if they have a problem, and not keep on looking here and there, because they would require immediate care. And then, of course, be very liberal in using magnesium sulfate, because there should not be any hesitance. Many times obstetricians are very hesitant to use magnesium sulfate preventive because of lack of experience and fear. Be liberal. Definitely the first 4 grams of magnesium sulfate can be given without any tension, and always be ready with hypertensive risk assessment and management. So in conclusion, when we look at what do we have at hand now, do a priori risk assessment even before conception if you have that window of opportunity, wherein you can tell her about how well she can plan her pregnancy 6 months ahead of she's getting pregnant, correct her anemia, obesity, chronic hypertension, hypothyroidism, PCOD, and diabetes as much as possible. You have so many maternal risk factors, calcium supplementations, and various kinds of things which you can screen the woman through, because now we have evidences through the SPRI, ASPRI, FMF, and the Gestosys score, and the CHIP study and the CHAP study has told us to use antihypertensive properly so that you do not allow these women to get into complications, and be always vigilant so that none of your patients have any eclampsia. So in conclusion, generally low sensitivities of the test evaluated refrain from testing, initiate preventive measures such as aspirin, and the ones which I've spoken to you about, calcium and lifestyle changes. And this particularly is my personal preference. So everything that can be counted does not necessarily count. Everything that counts cannot necessarily be counted. Thank you so much for giving me this opportunity, and hope I have been able to deliver what was expected of me. Thank you.
Thank you, Girija madam, for. Am I audible?
Yes, Madhuri, please.
Thank you, Girija madam, for a wonderful talk and enlightening the most dreadful entity of HDP. Usually, patients are not very serious about it. Many times, patient may come running to you when she has high-grade fever. But that patient will not understand the about the seriousness of her blood pressure. And madam, you have nicely told and explained about how to measure blood pressure, simple things, risk factors, and how to screen the patient, and importance of echo, which is a new entity for us also, and importance of protein in diet, and the unique one is a growth chart, which you monitor growth, weight of the patient. You monitor that chart is a unique one, and I congratulate my friend Dr. Sushma Deshmukh. She was a brilliant student when we were PGs. And so she's a brilliant gynecologist, brilliant social worker, writer, and brilliant endoscopic surgeon too. I am proud of you, Sushma. I thank
Actually, thank you. Madhuri, you all missed my previous words. in introduction. What I use for you all three, you, Girija and Rohan. I think you are not there for my introduction. I will just arrange all the words in a. I will.
Oh.
So we can request to watch the link again so that
sure.
we'll share the link. So you
please watch the link.
Sure,
Yeah.
sure.
For Girija also, for you also, there were important words for you.
Thank you so much. Thank you.
Yeah, it was really excellent and very nice, and just beyond that, really, I just no words to say. It was really amazing, as usual in different form, Girija.
Yeah. Thank you. This is our day-to-day practice and experience. Every day we do these things. It's high time that we started sharing our own experiences, because we ourselves are such huge encyclopedias of experience. Many times, for lack of evidence, we are, scared. We feel that what we are doing is right or wrong. But there are so many things that we do and they benefit patients. We need to documentation karna jaruri hai, but while we are talking like this, we can definitely share our experiences and do good for our patients.
Yeah, true. And you are having really very vast experience in HDPs, because I have been listening to you since Justice conference since many years. Yes, I think. And it's really wonderful, very nice.
Thank you so much.
Thank you very much, ma'am. Thank you very much, Dr. Girija ma'am, for enlightening us with recent advances in screening of hypertensive disorders in pregnancy. Thank you, chairpersons, for your valuable inputs.
We'll have a group photo also. Just Rohan, please add, but just please be here. We'll have a group photo. Just Rohan, please stop.
Yeah. No, I was just saying, actually, it's always really fantastic by Dr. Girija ma'am. And she's really summed it up well. In fact, there was so much of learning that even the case that we just discussed, okay, probably we could modify the management by, holding on, doing probably a placental growth factor in the same patient, seeing whether we really need to terminate. We could really wait, because, these are things which are ongoing. Yeah. What I learned, say, 10 years back is not really true anymore. And things keep on adding. So first of all, the case presentation and the way it went was fantastic, I think. And I don't know how many students are really watching it, but if they aren't, they've really missed a lot. And secondly, with ma'am, I mean, the way it has been put forth, I think it's fantastic. And, the fact that we could club all these things, like even screening for aneuploidies. If we add probably a PAPA or a placenta growth factor, that in fact, we do a PAPA in the dual mark in the first trimester combined screening. So that itself can be used for prediction of PIH, whether it's late or early. It's more for early preterm preeclampsia. And these things probably, if just one small addition, just like a BP management or details of the patient, if provided properly, and a uterine artery Doppler done along with the NT and NB every time the scan is done, if that's standardized, it would actually save us a lot of time and help us by, in a better management of such patient and help predict such things. It's all there. It's just about putting it probably in place. And I think what Dr. Girija said rightly in the beginning is the first and foremost, the history and examination of the patient should be standardized. I mean, probably it's now a race, to finish off patients or not seeing them properly. But if we don't really measure BP every time, or don't really take history properly every time, or don't really, a simple history of PIH in previous pregnancy, very, very important, is missed. And then probably later when it's quite late, that's when we realize. So I think it's really been fantastic. It's really been a good revision and a lot of things to learn, actually. So thank you.
I must share with you, Rohan, here, while you are saying this and appreciating, so many of our colleagues are now have just pasted the entire justice score on their antenatal cards. So even I have done my own antenatal card in my own thing. The first assessment, we have the justice score. And it's not essential that you do the ticking. My nurses and my clinical assistants do the ticking. They check the blood pressure. That time itself, they do the tick marks on it. So that I know that these histories are there, and then I ask the patient. So it's highly unlikely that you will miss, and it's right there in front of your eyes, which will keep on reminding you throughout. And the second thing is, Madhuri madam, I must share with you, is that weight gain. Bapre, I have picked up so many patients just by weight gain, that whenever that weight gain is just going beyond that line, you have to be careful and you will definitely
Yes.
catch them as early as possible.
That that chart,
Absolutely,
I
absolutely.
liked that chart idea, madam.
Nice, really very nice. You're really
Yeah,
doing
doing
very
the
great
chart
work.
for weight. Yeah.
Good evening, Girija madam. I have also done the research work on the gestosis score
Correct.
as uh, as a predictor for the severity. So we have found that all the cases who were having more than 3 gestosis score, they were directly connected to the development of the preeclampsia. But the rationale of increasing number was not directly associated with the severity of the disease. This was the ongoing. This is ongoing in the press for the Foxy
Fantastic.
also.
Madam, the moment you present it, na, just send me the reminder link. This is exactly what we are trying to look for. That is it really important to do risk stratification further? Does it make any change? That
Yeah.
would be a very valuable input from your end.
Dr. Giriza, as you mentioned about holistic approach, I will also take this opportunity to invite you all for the one wonderful conference on 17th of this September. That is with Brahma Kumaris. And we
Areva?
are just we had all the phases of that adolescent, reproductive, and the 40 plus. And we have combined all the medical problems and we are looking through the spiritual aspect with meditation and all. So this will be a very wonderful conference. I also invite all the PG students take this opportunity to listen. It's a one-day conference, 9 to 4, on 17th of September. So we are covering all the aspect from 9 to 4.
Uh, if I could just interrupt, I just wanted to ask Dr. Girija ma'am, uh, if there is a patient which according to gestosis score is at extremely low risk, no risk factors at all, would you go for a universal screening in this patient? Would you really suggest the patient does uterine artery pulsatory index, does PGLA, a placenta growth factors, or a PAP-A, a score? Would you recommend it for all the patients wherever possible?
See, no, I would definitely, universally, if you ask me, the screening would be, if at all, interventional. Now we are doing history score based, patients come low risk. Uterine artery pulsatility index, I would still want to vouch upon because that has helped us to be vigilant with patients around. Sometimes they will not have the PI increase at 12 weeks, they would be 16 weeks or 24 weeks. So whenever you get this opportunity, now, not all patients, we call them at 16 weeks. We would call maybe a threatened preterm or a high-risk mom, but she will also be positive gestosis score. But otherwise, you're doing it at 19 weeks. 19 weeks, we do the TFA scan. So that is the targeted imaging for anomalies. That's the time when you can do an uterine artery PI at this, as well as the cervical length, because we have such a high quantum of preterm births. And then you can consider doing it at 24 weeks if you feel so, but do it at 28 weeks, doesn't matter. 28 weeks la growth scan if you are doing, you can consider doing the uterine artery PI there. The thing is that many times, many of the sonography services do not have an additional Doppler, screening all across our country. That is the deterrent. Secondly, sometimes we are not very confident about how the Dopplers have been measured. So an obstetrician himself or herself can do it and learn the technique, or maybe use it. So that's why we don't speak about, because whenever we are talking of any kind of a study, we always are concerned whether this will be uniformly available to all those mothers in our country. But if you are doing it already, why not look at it? I have had patients, like my students are all across the country. Recently, one of my students who's practicing in Malegaon, he had a eclampsia patient sent to him at 33 weeks of gestation. And he managed her, and he told me, this was the first time the patient had come to him. He showed me a sonography report which was done at 26 weeks. And it clear cut that uterine artery PI was raised, but nobody had looked at it. So if we would have known that time itself, we could have been careful now with this patient. I like how I told you, Rohan, that I will give a lot of importance to biometric fetal growth month restriction even in the absence of uteroplacental insufficiency. I would still pay attention to this woman because there is placenta is not able to supply. त्याच्यामुळे developmentally कुछ तो placenta में हो गया है, be vigilant.
Yes, yes. So probably awareness, I think, is the key right
जो
now.
भी हमारे पास है ना, जो भी है, उसको carefully पढ़ना, read it. And
Yes.
if you are too busy in your practice, teach your assistants. You'll not believe I have 2 nurses in my, I don't have any clinical assistants in my private practice. There are 2 nurses who are managing my practice. They will read the report and say, Madam, तिचं असं झालंय. They have been working with me for the last 15 years. And they are all absolutely aware. They, sometimes if I'm late, they will know. They'll do NST, they'll do PO2, they'll do uterine artery. They'll do fix up their sonography, proteinuria, and they will tell me, Madam, हे असं असं आलंय. She's not feeling well. She's feeling uneasy. See, this sensibility, you have to keep on continuously talking to your people so that we increase that sensitization and sensitivity to these things.
Absolutely. Absolutely.
Madam, one question in continuation of Dr. Wahan's question, that if we can find out at 26 weeks of gestation that the PI is raised and this patient is going to have the preeclampsia. So should we start the aspirin at that time also, apart from being vigilant for the decreasing other parameters for the preeclampsia complications?
Yeah. Now, if such a patient comes to me at 26 weeks, I will definitely start her on 150 milligrams of aspirin because I will give her that prostaglandin advantage. I may not influence her placental changes which have occurred now, but whatever prostaglandin imbalance and inflammatory, anti-inflammatory actions that low-dose aspirin have, the latest you can start aspirin is at 28 weeks of gestation to give her a benefit, a little benefit. Effective is always starting at 16 weeks or earlier.
Yes.
But you can give her that much benefit. Maybe it will not be as effective as it would have been earlier. That's one.
Right.
And
Right.
I would also like her, Jyoti, to give LRG9 and high protein diet is something that I will really tell her.
Yes,
Yes,
ma'am.
practice karo. Screen her for hypothyroidism and diabetes.
Yes. Thank you,
Girija
madam, for
madam.
your inputs. Especially the protein part you have added to in today's lecture is really impressive, and we should tell every patient to increase the protein content in her diet. Thank you so much.
Girija madam, I want to ask one question because many PGs are there. That's why.
Yeah.
If patient is at 32 weeks and she develops PI, it means that her blood pressure is 140/90. How frequently we should do her blood test?
See, first and foremost, you do a urine protein.
Yeah.
If her proteinuria comes positive, that means she's preeclampsia baat khatam. Now surveillance, and then shortly you'll have to deliver after till the time that her labs remain normal or she doesn't develop any severe features. But if she has no proteinuria, then overtly she's gestational hypertension. You can consider doing her protein creatinine ratio. Now here, the protein creatinine ratio in a singleton pregnancy comes 30 or more. She has developed microalbuminuria. She is going to head towards preeclampsia. So 1 weekly, and if she has come absolutely no proteins, no even microalbuminuria, 1 weekly you can consider doing it. Depending on how severe she's going. If she's really having, all these symptoms and signs, maybe you can do, here is the place for telling them to do home BP monitoring, madam. We give them a chart and ask them to do their blood pressures either at home or by nearby doctor. So many of my patients walk into the clinic also. They come to the clinic, they are not charged. When the nurses are around, they get their blood pressure checked and go. So this also can be done. Give them an where they can keep on checking their blood pressure at least every 72 hours.
Whether we should monitor them by doing complete blood count?
Not really. I wouldn't say if everything is fine, then it depends on the clinical situation.
Okay.
There are no standard protocols to say how frequently it has to be done. It will have to be individualized based on the patient's presentation.
Yeah.
I can give you an example of a woman who started putting on weight from 16 weeks onwards, terrific weight. इतना कि she was putting on weight at the rate of 3 kg, 4 kg, very irritable, very anxious she was. And she had Dopplers which were high. I had put her on low dose aspirin and all these high protein diet, exercise, all kind of jamela I did. But at 32 weeks, she was so swollen up and she said, I'm not feeling at all well. And I said, let's get your 2D echo done. And she had started developing a cardiomyopathy. And not only that, I admitted her and I also sent her PLGF for testing. But before, and I gave her antenatal steroids, magnesium sulfate for 24 hours. And then after that, after about 48 hours, she said, I'm having breathlessness. And we diagnosed her to have actually pulmonary edema, which was no fluids were given to her. This was just hypertension giving rise to. Meanwhile, that PLGF didn't turn up. And her NST started showing abnormality. I said, बस हो गया बस, अभी चलो हम सीजर करते हैं आपका. And because we had done 2D echo, we knew pulmonary edema, fluid management, everything went well. And delivery, we landed up delivering a 32 to 33 weeks baby. The baby is doing very well. But then this patient continued to have blood pressure for about a year after this. So, this you can see that it is all clinical management only, no, madam. What did I do? Just be vigilant there, PLGF turned up later on. And that, it took a long time because all labs are not very well versed with doing it. That's a kaitari level came between 12 to 20 अशी kaitari आली होती PLGF. So if it would have come early, I would have terminated her. So it was correlating. But there are, this, what you say are logistic issues are there. एक तर cost आहे, access आहे. आपल्या आता पुण्यामध्ये आमच्या इतक्या लॅब्स आहेत ना, ते सगळं मुंबईहून सोर्स करतो, इकडून सोर्स करतो, अशीच उत्तर आहे. How can you have these tests very easily available to patients? Maybe we must consider doing some drop test or something will come shortly. That may help us, that you yourself do the spot test.
Yeah.
Thank you.
Yeah, really, it was really wonderful discussion. It will never end because the PIH is always, it will come again and again, I think.
Then everybody, I always feel that everybody is such an expert in it now. So we should always be very confident about our expertise. There'll be lots to share. Apla pahila reaction towards preeclampsia is fear, scare, whether I'm doing right or wrong. Don't worry. We are doing right. Are Shobha, I'm in a webinar. I'll call you now in 2 minutes. Give me some time. 2 minutes.
Thank you very much, Girija ma'am, for inviting us with recent advances, dietary management of a PIH, and thank you, chairpersons, for your valuable inputs.
Thank you. Thank you.
Thank you, respected seniors, teachers, students, for your gracious presence and excellent inputs. Thank you, all the audiences. Thank you, NOGS and GMC Chandrapur, for giving me the opportunity. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Bhakti and entire team to involve us in this academic phase. Thank you.
Yeah, thanks a ton, Dr. Bhakti. She was the one who was coordinating.
Yeah.
There's a very wonderful academic team is with me, and everybody is really doing wonderful.
Correct. Very nice.
Thank you. Thank you, Madhuri. Thank you, Rohan.
Thank you. Thank you, ma'am. Thank you so much for giving the opportunity.
Bye-bye, Sushma madam.
Bye. Bye, Dr. Anita.
Thank you, ma'am.
Yeah.
Sushma, really, I am proud of you. Yeah, you are doing so much for PGs also.
Yeah, actually,
really.
I thought they actually, what is happening actually, the many times, many are just inquired, PG activities are not there. That's why in some colleges, that's why I started this, and really I'm getting wonderful results.
It's a very, very good initiative. Yeah.
Yeah.
I must appreciate
Madhuri,
you.
and thank you very much.
Arre.
Yes, I can see your Madhuri smile. You must listen to this previous video.
Yeah, sure. Definitely.
And Rohan really was very good. Rohan had really very good talk on our Garbha Sanskar. That's why I suggested Rohan's name.
Rohan, okay. But still you are continuing. this
Yeah,
Garba
it's,
Sanskar.
yeah, it's continued. I will send you the link also.
Yeah. Chalo.
Okay, chalo.
Bye, Sushma.
Thank you.
Yeah.
Thank you so much, ma'am.
Thank
Thank you
you.
so much for the
Thank
opportunity.
Thank you very much.
Thank you.
Thank you.